أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والعاقبة للمتقين والصلاة والسلام على رسوله الكريم سيدنا محمد وآله وأصحابه أجمعين برحمتك يا أرحم الراحمين. All praise due to Allah, the Lord, cherisher, nourisher, sustainer and master of the universe, the most gracious, the most beneficent, the most merciful. Ya Allah, it is only you that we worship and it is your guidance that we seek. Ya Allah, keep us in the straight path. Ya Allah, shower us with the choice of blessings. Ya Allah, shower us with the mercy. Ya Allah, guide us. Greetings, salams, salutations on our beloved Nabi Muhammadur Rasulullah sallallahu alayhi wasallam. We welcome you to Medical Files, brought to you by the Islamic Medical Association of South Africa, and it's hosted by myself, Fazial MJ Suleman. Assalamu alaikum wa rahmatullahi wa barakatuh, and we welcome our listeners on Radio Al Ansar, CII Radio, Voice of the Cape, Radio 786, Sirius FM, Radio Islam and IFM Port Elizabeth, and all listening to us on audio streaming and other platforms. Our topic for discussion this evening is skin cancer, and our very special guest this evening is Dr. Presha Bipath, a clinical oncologist. Dr. Bipath, good evening to you and thank you for joining me on the program this evening.
Faisal, and walaikum salam to the listeners. It's a pleasure to be here. Thank you for having me.
It's an absolute pleasure hosting you this evening, Dr. Bipath. Now, just to introduce Dr. Presha Bipath, she is a clinical oncologist who completed her specialist examination from the College of Medicine, South Africa, as well as a master's in radiation oncology at the University of KwaZulu-Natal in 2021. She is currently based at the Nkosi Albert Lutuli Hospital in Durban. Now, Dr. Presha Bipath, I introduced you as a clinical oncologist. Who or what is a clinical oncologist?
So a clinical oncologist is an oncologist that does all aspects of treatment in cancer care. So there are centers that divide them into radiation oncology and medical oncology, which means that some centers do radiation alone and some centers do chemotherapy alone. So a clinical oncologist will incorporate both aspects, all aspects in the treatment of cancer care. So we do both radiation and chemotherapy in the management of cancer care.
So a clinical oncologist is more involved in treatment and management of the
it's
process.
Yeah, but it's all aspects of the management, not just the radiation and not just the chemotherapy.
Now, I did say that our topic for discussion was skin cancers. Now, what are skin cancers?
So cancer in itself is the development of a mutated cell, which means that normal cells grow and divide, and somewhere along this division process, there's a mutation that occurs and develops an abnormal cell. So when we derive that to skin or skin cancers, this happens in the cells in the skin. And there are multiple types of cells in the skin, and we'll dive further into that when we talk about the different types of skin cancers. So basically, the cells in the skin develop a mutation, and from this, as and when it divides, the mutated cell continues to divide, and this forms a mass or a tumor or an ulcer or a plaque, etc., that then will further invade into the surrounding structures and spread itself into the body.
So skin cancer is something that can spread into the body, spread into other parts of the body, other organs, etc.
Yes, it can, and obviously it varies into the different types of cancers, and there are the skin cancers, and some are more likely to spread and some are less likely to spread. But all types of skin cancers, if left untreated for long periods of time, can definitely invade through the surrounding structures, through the bloodstream, through the lymphatic glands, and deposit itself in areas where it hasn't originated or to a distant site in the body.
Now, you speak of the global burden and you speak of the national burden. What does this refer to, and what's the difference between the two?
So skin cancer is in itself a global burden, but it also varies from nation to nation. And when we look at the global burden of skin cancer, we know that it's the 5th most common cancer that's been diagnosed worldwide. It's also has the incidence of 1 in 5, which means that 1 in 5 people are diagnosed with skin cancer throughout their lifetime. Now, when we look further down in South Africa, now it also ties in with our statistics. Obviously, in areas where there's high UV exposure, like New Zealand and Australia, the incidents are a bit higher. But South Africa is also such that it's also been one of the 5th most common cancers diagnosed, and we're also at a higher rate because we have a high incidence of immunosuppression, which is one of the risk factors for the development of skin cancer, which we'll talk about a bit later. So it is definitely a national burden to South Africa itself. The other issue is that when we look at South Africa, in the way we manage these cancers, drug and access is also a problem. And we know that our patient population is notorious for delayed health-seeking behavior. So that is why it's more so a national problem.
Now, our government hospitals or our public sector, are they equipped to deal with this?
No. Well, yes and no. So when it comes to managing early stage skin cancers, a government institution or a state sector can very well manage this and very easily manage this, especially if it's detected early. But when you look at your more advanced cancers and the specific types of cancers, skin cancers, for example, a melanoma, it's predominantly managed by what we call immunotherapy. And this is unfortunately not available in the state sector because these drugs are very expensive.
Absolutely.
So the state will not fund this. So, but it's paramount that this is detected early, whether it's state or whether it's private, because this obviously influences your cure rate.
Now, we spoke of detected early and detected late, etc. What are the symptoms of skin cancer?
Okay, so when we look at any suspicious lesion on the skin, we have certain characteristics, and what we describe it, an easy way to remember it is A, B, C, D, E. And starting from A, what that describes is that the lesion or the mole or the plaque has what we call asymmetry, which means an asymmetry, as we know from geometry, is that it's not in a conformed or the same size or shape if you divide it in half. So this is one of the signs of something that could be dangerous from a lesion that could be cancerous, is that it's asymmetrical. Then we look at B, and that stands for borders. Now, usually when you develop a lesion that's suspicious for skin cancers, they have very irregular borders, as opposed to something like a benign mole or a non-cancerous mole, where you can see the borders are very confined. Then when we look at C, we talk of color. And usually this means that the color of the actual lesion is varied, and it can be from pink to brown to black to, even if it's at the very early stage, it can even start with being white. Whereas opposed to something that's benign or non-cancerous, where the color is a bit more uniform. Then when we talk of D, we speak of diameter. And the diameter, as it's described, is anything that's more than 6 millimeters in size, and that's basically the size of a pencil. So any mole that is obviously more than 6 millimeters in size is worrying. And obviously this is something that is not a blanket rule, and it doesn't necessarily apply to everybody, and it's not here to create alarm. It's just so that we create awareness as to what could be dangerous or not. The other thing is that the size, obviously, or the diameter is forever increasing. Now, but something that's non-cancerous will be a bit more delayed in how it grows and progresses. But a cancerous lesion obviously grows and spreads at quite a rapid rate. And the last factor is E, which is something called evolution, which means the actual dimensions of that cancerous lesion is forever changing. It's not consistent in terms of its size, in terms of the way it looks, in terms of whether it's solid or whether it's a bit more cystic. So those signs, or if you have anything on your skin that follows this A, B, C, D, E rule, then obviously it is a cause of concern that this warrants further investigation, or you should get tested to exclude a cancerous lesion.
And what are some of the investigations that you carry out? I mean, if I had to come to you and show you something that, looks cancerous to me or whatever, what sort of, how will you sort of, before you diagnose, you'll have to do certain things.
Yeah.
What are you going to do?
So firstly, all tests or all visits has an examination or a medical examination, and this too warrants for the skin. We do a clinical examination of the skin, and this could be the lesion itself, and there are certain things which we call mole mapping, and then a dermatologist will have an equipment where they can look at things under the microscope to further clarify, or look at the lesion, even the smallest lesion under a microscope, to see if this is worrying. If they have signs that are worrying for cancer, then they do a biopsy. And this can be very simple in terms of shavings to an actual excision biopsy. This then gets tested or goes to a lab, and now we're very fortunate in that some of the labs we can get the test results within 24 to 48 hours. And if this comes back as a cancer, then further investigation is warranted, and this is either to assess if it has spread to beyond the sides of the skin, and that includes the glands or the other organ structures. This can vary from an ultrasound to a CT scan to stage certain cancers, and even now, even a PET scan for certain type of cancers is warranted to stage.
Mm-hmm. No, thank you. So, if I've got that sort of, if I suspect something, I go to a dermatologist first.
So, most often than not, people don't present to a dermatologist for a skin condition. They usually present to their primary health care physician or a GP.
To the GP, yeah.
But this is sufficient enough to identify something that's cancerous or not. We then expect that physician to then refer to a dermatologist, or if he is trained or he or she is trained to do a biopsy, they're more than welcome to proceed to a simple biopsy. However, it's preferred if this is done by somebody who's experienced or more trained in identifying, like a dermatologist or a plastic surgeon, to go in and biopsy this lesion, so that sometimes it's taken out in its entirety during that biopsy site.
Thank you, Dr. Bipath. You're listening to Medical Files, brought to you by the Islamic Medical Association of South Africa and presented by myself, Fazial M.J. Suleman. Our topic for discussion is skin cancers, and our special guest this evening is Dr. Presha Bipath, who is a clinical oncologist. Now, doctors and guests on the Medical Files program will help you with any medical problems you pose by giving you advice on air. However, they do not have your full medical history and have not examined you. Please verify the advice given to you on air with your regular doctor who knows your medical history, allergies, etc. Neither the doctors nor the relevant radio station nor the Islamic Medical Association of South Africa will take any responsibility for any adverse reaction caused by the advice given on Medical Files. Now, this is an interactive program, and if you have any questions for Dr. Bipath, you may forward them to us via WhatsApp on 060 904 1056. I repeat, 060 904 1056. The topic for discussion is skin cancers, and our guest is a clinical oncologist. So the questions must be restricted to skin cancers and oncology. Dr. Bipath, I want to classify the different types of skin cancers. I mean, you did mention there are different types of skin cancers. Let's do a broad classification of that.
So it all depends on the site of origin, and the skin has different types of cells in them. So you get your squamous cell carcinomas, which originate from your squamous cells. Then you get basal cell carcinomas, which originate from your basal cell in your skin, or the basal layer of your skin. And then you get your melanomas. And your melanomas originate from what we call melanocytes. And melanocytes are the cells that cause the pigment in your skin. So everybody has a different number of melanocytes, and this varies from, and this is what causes our varying in color. And then you get other types of skin cancers which are less common, and this is Merkel cell. So this is a specific nerve cell that's in this layer of the skin that develops a malignant transformation, and we call this Merkel cell. Then you get classified other types of skin cancers, which are not necessarily skin cancers of skin cancer origin, but have cutaneous manifestations of their disease. And this includes Kaposi sarcoma, your cutaneous T-cell lymphomas, and even primary sites of a breast cancer can form dermal metastases, or can have deposits in the skin, or even certain salivary glands can even have skin deposits, which we call dermal metastases.
Now, you did mention that 1 in every 5
Yes.
have skin cancer, but I mean, it doesn't seem to be too. Can I say it doesn't? We don't hear of many people having skin cancer. We hear of all other types of cancers. So, is there a particular demography of the population that gets it? And the next question is, what causes it?
Okay, so yes, there is a certain demographic that are predisposed to getting skin cancers, and usually what the data has found is that the patient population with the light skin and the light hair and the light eyes. So yes, this is all very well and beautiful, but unfortunately it's noted that this patient population is predisposed to sun damage in the skin. However, in South Africa, like we said, there's a certain type of skin cancer which is called a melanoma, which specifically occurs in the black population. There's a specific type of melanoma that occurs in the non-sun exposed areas, which is often commonly seen in the pigmented patient with the black population.
Okay.
So, but I think the reason why we don't see it is because, yes, our patients are predominantly black in our country, and we don't have as high number of statistics as the light-skinned, light hair population. However, when it comes to melanoma, it must be noted that they often present very late. in terms of its presentation. So that could be the reason why we don't see it as commonly in our population. Now, when it comes to risk factors for the development of skin cancer, we usually divide them into modifiable or non-modifiable. So this means things that we cannot change that increase our risk, and things that we can change that increases our risk. So things that we cannot change that increases our risk of developing skin cancers are things that we have in terms of a mutation. Now, there is a skin condition which is called xeroderma pigmentosa, which predisposes one to skin cancers. Now, may sound a bit high-end, but it basically means just a pre-existing skin disorder. Now, this is more often than not diagnosed on its own. So these patients that have been diagnosed with this are at a higher risk of developing skin cancers and obviously need to be monitored. And then you get a patient population which is called albinism. Now, albinism is a predisposition or a genetic disposition where the black population have less pigment in their skin, where they're light in color. They have light eyes, they have light skin, and they have light hair. And then we have another unmodifiable risk factor, which is immunosuppression due to a transplant recipient. Now, this is not something that we can change. However, there is another immunosuppressive entity that we can modify. But the transplant recipients, unfortunately, are classified into unmodifiable risks. Now, when we talk about modifiable risks, there are things that increase our risk of developing skin cancer that we can obviously change. And this includes sun exposure. Now, sun exposure increases your risk of developing skin cancer, and like we said, it is more so in the light population, in the light skin, light hair, but it doesn't mean that those that have normal pigment in their skin cannot develop skin cancer if they have excessive amounts of sun exposure. Then we have things like smoking. And smoking predisposes your risk to the development of all cancers in general, but also has been associated with skin cancer. So smoking cessation is definitely a must. And the other risk factor that I've said before is immunosuppression. And we know that our patient population, or South Africa, has the highest number of, one of the highest numbers of HIV positive patients. Now, this in itself obviously is uncontrolled. If uncontrolled, causes a significant amount of immunosuppression, and this predisposes one to the development of skin cancers. So this is the most common risk factors that we've identified, or that's striking in the data, is for the development of these different types of skin cancers.
Now, having mentioned those risk factors and for the development of skin cancers, what can one do to prevent the development of skin cancer?
So, like I said at the beginning, smoking cessation. So this is something that we know has not only prevents or skin cancer, but because smoking has been identified associated with most cancers, smoking cessation can definitely decrease your risk. Another preventative measure is sun protection. And now it's not only sunlight, but it's the actual UV exposure. So we get that from the sun. So, and most of the time, the strongest UV rays is between 10 a.m. to 4 p.m. So during these times, it's expected that when we do go out in the sun, then we need to protect ourselves. And this can be done by using hats, using long sleeve clothing, or even using sunscreen or sun protection. And this is obviously more an SPF 30 or higher that's recommended. Another preventative measure is that if you are going to go into the sun, and we know that we all like the sunlight, there are things that you can do, like vitamin A and fatty acids. So any serum that you use that have vitamin A or serum or fatty acids, obviously not in excessive amounts, this has been shown to not really prevent but decrease the development of skin cancers.
Question has come through, is this condition curable, and what is the death rate?
So I'm going to do the inverse.
Yes.
The cure rate, if it's detected very early, is up to 80 to 90%. So yes, skin cancers, most of them, if detected early, can be cured. And like I said, up to 80 to 90% cure rate. So the inverse is about, the death rate is about 10% maximum.
Okay.
However, this is only true if it's detected early.
Okay.
Now, they are in the very type of skin cancers that are associated with the worst prognosis. And obviously, this may be a bit higher higher in terms of its death rate. And this is, like I said, Merkel cell carcinomas, which is very, very, very rare. And that's probably the reason why our statistics are such. And then we have something called a melanoma. Now, melanoma can be dangerous. If it's not detected early. This is one that can spread very easily to the nodes, to the lungs, to the brain, and this can be fatal. So if this is not detected early, then yes, this can lead to quite a significant number of fatalities.
Melanoma seems to be very common amongst all the different types.
Melanoma is common. Melanoma is one of the skin cancers that is common. And also, like I said, in our patient population, the less sun exposed, the pigmented patient, they also have the higher risk of developing a specific type of melanoma, which we call your acrolentigus melanoma.
I don't know how you'll remember all this fancy terminology. Yeah. You did mention that there is treatment available. You did speak of radiation. You spoke of what's very famous now. You do different types of treatments.
Yeah.
What are some of the type of treatments that you do?
So at the beginning of your diagnosis, usually for skin cancers, the main modality of treatment is surgery. And this means a surgical excision or a removal of the lesion. And this is obviously if it's what we call localized, which means it hasn't spread to the surrounding glands or the surrounding visceral or organs. Now, over and above surgery, once this has done and if it's completely removed and there's no other what we call adverse features, which means features that would increase your chance of this coming back, then obviously it just means monitoring. Now, for those are for early stages. Now, when we look at a bit more of an advanced stages, then we look at surgery combined with radiation. Obviously in the adjuvant setting, which means after it's been removed, so radiation to that area or the surrounding glands if they've been removed, to decrease the chance of cancer coming back, or what we call in layman's terms to sort of sterilize that area from cancer cells or any seeding of the cancer cells in that basin. And then we also have chemotherapy for certain type of cancers, and this could be for your squamous cell carcinomas that we commonly use chemotherapy in the bit more advanced setting. And with melanomas, there's a thing called immunotherapy, which is something a bit more novel. Now, immunotherapy is newer drugs, and these are the ones that are a bit more expensive. And one of the ways that cancer works is that it has the ability to evade the immune system. So this immunotherapy drugs are sort of game-changing in the management of this cancers, and like I said, melanoma, in that it can cause your what we call a progression-free survival, which means keep your cancer latent for significant periods of times. And this is well beyond 2 to 3 years, which is something that's quite phenomenal for managing advanced cancers. Even in your stage 4 setting, when we look at cancers that have spread to other parts of the body from its originating site. Then we look at treatments like radiation to help for symptom control. We can even look at surgery to help with symptom control. And when we look at also treatment for localized melanoma, there are things that we can use, which is lymphofusion. And looking at now newer therapies, they've even adapted, with the mRNA technology that we've used for COVID vaccinations.
Yes.
They've looked at it in a study in what we call lymphofusion therapies for managing melanomas to the limb. And they found that as yet, there hasn't been anything striking in the data in terms of it being more superior than standard of care. Whether this is going to change in the future, we have to wait and see.
Okay, there's a little question. I don't know if you can call it a question, but it comes from one of the listeners, and it says that immunotherapy will attack those cells that are damaged, or attack the cancer cells, as opposed to chemotherapy, which will knock out everything. Is that correct?
So both these drugs are given either via drip or through the mouth, which means that it's absorbed through the bloodstream. So it has effects to other parts of your body, and it will affect multiple sites of the cancer deposits. So not necessarily true that chemotherapy differs in immunotherapy in that way, but one of the ways that cancer grows is that the immune system is responsible for attacking and killing off something foreign to the body. Now, this cancer cells evade that. So what it does is this immunotherapy makes the immune system stronger in identifying and attacking. So it will clear out the cancer a bit more better, in that even sometimes if it's a resistant type of cancer or resistant to chemotherapy, then immunotherapy has a role in clearing out the cancer cells a bit more effectively. However, immunotherapy drugs have its own set of side effects, which, if not also monitored properly, can also lead to some serious side effects.
But where are the side effects more worse? In the chemotherapy or immunotherapy?
So because we've been using chemotherapy throughout, and chemotherapy is notorious for having the general side effects of making you tired, causing you to vomit, making you weak, giving you diarrhea. In a sense that chemotherapy is a bit more stronger in terms of the side effects. However, some of the immunotherapy drugs, depending on what type of drug it is, can also cause some serious side effects, and these include what we call a pneumonitis, which means an inflammation of your chest. Now, obviously, this can be graded, and if it's a grade 4, then can lead to even fatal complications. So, yes, not commonly noted in terms of these side effects in immunotherapy. So, chemotherapy does have potentially serious side effects as opposed to immunotherapy. However, like I said, they can also cause some serious complications.
Now, what do you do if you suspect you have a lesion that could be cancerous?
Right. So if you have a lesion that could be cancerous, you go to your nearest healthcare practitioner or GP, and then obviously they biopsy. Sometimes, even if it's very, very small, and if it's at a point where it's not easy to remove, like the nasal bridge or a location where in your face where it can lead to a cosmetic problem, then they can even give you creams. And this is like chemotherapy form of creams that you can apply to these lesions and obviously monitor and see if this is going away. And this is only if it's very, very, very early, and obviously you have a biopsy that confirms, even if it's just a shaving, to say that these are cancerous cells, because then you wouldn't want to give chemotherapy unnecessarily to something that isn't a cancer.
Absolutely, absolutely. The consequences can be quite drastic. How are skin cancers broadly treated?
So at early stage, it's we do a surgical excision, or even at very early stage, you can look at creams or topical creams or chemotherapy form of creams that they administer. Then you can do microsurgery, which means shavings to the point where you only exclude the area that is negative, or take in only even a millimeter of normal tissue. And then obviously in the more advanced stages, then you remove the primary site or the surrounding glands with surgery. And then in the more advanced stages, you can follow through with chemotherapy, you can follow through with immunotherapy, you can follow through with, like we said, lymphofusion therapy. You can even follow through with radiation in the adjuvant setting if there's indications for this.
So let's look at the patient. What sort of lifestyle that patient's going to now endure, knowing that he's been to this treatment? It's going to be like the normal cancer patient that we see that's going for chemotherapy, radiation, etc., or with the skin cancer it's slightly different?
With skin cancer, it's very, very treatable. And one of the good things about, or shall I say a good thing if I may, is that skin cancer develops in what we call sun-exposed areas, which means that this part of the skin is very visible to everybody. So obviously it's easy to identify, even if the patient doesn't see it themselves. The surrounding family would say, hey, you've got a lesion on something that I can see, go and get it tested. So this is one of the reasons why skin cancer is, as opposed to another type of cancer, detected early. So these patients, like I said, have a good prognosis in that they can live a fulfilling life, a happy life, a long life, a normal life, as opposed to something like a liver cancer. Or like even sometimes some types of breast cancer, which are more aggressive. So skin cancer doesn't necessarily mean that you're going to live a life full of chemo, full of radiation, full of surgery. This being said, even now with the more advanced techniques, we can even downsize the cancer if it's an advanced stage with immunotherapy to ensure that the surgery is not as extensive as it would be without, which means the complications even from the surgery are less if you're taking out less of the surrounding structures.
You listen to Medical Files, brought to you by the Islamic Medical Association of South Africa. Our topic for discussion is skin cancers, and our special guest is Dr. Presha Bipath. a clinical oncologist practicing at the Nkosi Albert Lutuli Central Hospital in Durban. Now, Dr. Bipath, what is emerging or newer therapies that can be adopted in the management of skin cancer?
So immunotherapy is something that's changing throughout, and there are a lot of drug trials, like we said, for skin cancers, even melanoma, that the drug companies are bringing on board. So even with the immunotherapies, there are specific types of immunotherapies or novel therapies that are emerging. So that's one of the things that we need to look out for. Obviously, like we said, these drugs are a little bit more expensive. So the clinical trials allows us to access these drugs without having to bear the cost. So that's one of the newer things that are out. And also, like we said, the lymphofusion with the viruses or the viral vaccines. So with the mRNA technology that they've looked at in terms of treating the COVID vaccine, they've adapted that mRNA technology to see if this can be treated with melanoma of the limb. And so far, it's not inferior than standard of care, which means that it can be used as an adopted alternative. It may not necessarily be superior than what we use currently, but if you don't have any other treating options, then this is certainly an option. The other type of newer emerging aspects of treating melanoma is this thing called a genetic relapse score. Now, we use them for cancers like breast cancer, where after the cancer has been removed, we can do mutational studies to give us a score to assess what your rate of relapse is. Now, obviously, this is something that we know can help us identify or institute treatment early on if the cancer is removed, or even monitor these patients closely. So this is something that's newer now when it comes to specifically melanoma, to assess on the mutation of the cancer itself. If you have a higher recurrence score, then obviously you would institute treating sooner rather than later. So far, that's what is currently, things that we need to look out in the future. And this makes treating skin cancer a bit more manageable, and it also gives us a bit more positivity in managing these cancers.
Now, you spoke of clinical trials.
Yes.
Are these easily available in South Africa? I mean, and if they are, how does one become part of this trial?
So they are easily available. Melanoma is something that's looked at quite under the microscope when it comes to these clinical trials, because it's very, very heavily driven by immunotherapy, especially in the advanced stages. So availability of these trials in South Africa isn't an issue. There is a lot of availability of these trials. Now, when it comes to access and enrolling these trials, we are trying to get some of these trials into the state sector. Now, this obviously has to be done with the university and with the clinical trials unit. So this is something that we're trying to do. But currently, as it stands, there are a lot of private oncology centers that have clinical trials growing. For enrolling these trials. So what happens is you either present to those oncologists, or even if you come into our state sector, then we will contact this trials unit or this oncology unit and ask them if they're currently enrolling. If the patient meets the criteria or fulfills what we call the eligibility criteria, there may be certain workup that's required, there may be certain tests that are required. If they meet the criteria, then we send them with the referral pack to the center for consideration for this clinical trial. When this is done, then they have a clinical trials unit with a nurse and a clinician who will take the patient through the process of the clinical trial. Obviously, there's a whole lot of consent that's involved, a whole lot of monitoring of these, of the administration of the drugs. Some of them are blind, some of them are not. In that we don't know whether you're getting a control or whether you're getting the actual drug itself. And like we said, some of these trials are showing some promising results, even though they've still new and emerging in their
I was just going to
phase.
ask you, how successful are these trials? And you said they are showing some promising results.
A lot of them are showing promising results. Now, for people like us who are in the state sector, we're very limited in what we can offer for patients with certain types of skin cancer. So it opens us a lot of opportunities for our patients in terms of access, because a lot of these trials are funded by drug companies, which means that the government or the patient doesn't necessarily have to bear the costs of these.
Now, there's obviously myths about skin cancer and other type of cancers. What are some of the myths about skin cancer?
So some of the myths is that I'm dark-skinned, I wouldn't get skin cancer. So yes, we know there's an association with the light skin, light hair, light eyes. However, like we said, there is a specific type of skin cancer that occurs in the black population or the dark-skinned population. So it doesn't necessarily mean that because I'm dark-skinned, I'm not going to get skin cancer. So that's a myth. The second myth is that it's winter and I'm going out in the sun, I'm not going to increase my risk. And this is not so, because whether it's a summer sun or whether it's a spring sun or whether it's a winter sun, UV exposure is UV exposure. So this should be limited, like we said, as in when you go out between 10 a.m. to 4 p.m., you go out with some protection. And obviously, the certain amount of UV exposure is good and healthy. We know we get vitamin D. And it's good for your psychological well-being. So this is warranted. But what's being shown is that excessive amounts of UV exposure, and this so is chronic sun exposure, and this is so for what we call outside workers. If they go out every day without any sun protection, then obviously they increase their risk of the development of skin cancer, whether it's the summer sun, whether it's the winter sun. The other myth is that skin cancer is not a serious problem. So yes, it is one of the cancers that is associated with what we call a better prognosis, and it's something that's very, very treatable. But it is a problem because it is a cancer. Exactly. And if left untreated, even in the early stage, I mean, if it's something that we're not worried about, then it can obviously grow and progress to something that is definitely something for us to worry about.
When you use the C word, then it's obviously frightening.
Yes.
The minute you hear the word cancer, it's frightening.
Yes, whether it's early stage, whether it's a mild cancer, a cancer is a cancer.
Let's talk about the effects that it has on the family of the patient, and what do you expect from the family of the patient? What role do they play?
So right at the beginning, sometimes, like we said, it's the development of skin cancer is usually in the sun-exposed areas. So sometimes the patient itself can't identify the lesion. I mean, sometimes it's something that they get used to seeing. Sometimes they think it's a pimple and they assume that it's a pimple. So there's a lot of support from the family that they can identify something that's suspicious. I mean, they're looking at you all the time. So even if they notice something's different, then they should obviously alert you to that. Then there's also, we're part of a community where we're not open to going to the doctor. We don't want to go to the doctor. We don't want to go to the hospital. We don't want to seek treatment for whatever we think is normal. Maybe it's because we push things under the carpet, or maybe because we ourselves are afraid of hearing what we need to hear. So there's support from the family in that, even if it means going with you, let's go and let's get it tested. So the support structure that the family provides is magnanimous in that amount. Now, even during treatment, we see a stark difference for a patient who has poor social support, poor family support, as opposed to a patient who has a strong family support. And, somebody who's there taking them throughout this journey, even if it's somebody holding their hand and telling them it's going to be okay. You just need to hear that it's going to be okay so that you're not going through this alone. So the psychological aspect of family support is something that, we can't put any value to.
Absolutely.
Now, even when it comes to managing side effects of the treatment, I mean, there are points in your time if you're on chemotherapy where you're vomiting and you have diarrhea and you're weak and you can't cope with, being alone. There's a lot of support that your family members will provide in this regard, and we dictate treatment decisions based on this. If you don't have a good social support and if you're not going to cope with the treatment, then obviously it's a reason for us to avoid certain treatments as opposed to giving it.
All right. So you can't do without certain treatments.
So there are aspects of cancer where we focus on quality of life. And sometimes a lot of the treatment can impair that quality of life.
Absolutely.
So if the treatment's going to make you more sicker, and if it's not going to change the outcome, then we might as well avoid doing it, especially if it's something that you're going to go through alone. It means it's something that you're going to struggle through.
No, absolutely. I think it's absolutely vital because you need that support structure.
Yes.
And that support structure is vital. In fact, it can win you, I think, 80% of your battle.
Yes, definitely.
Now, you spoke of treatment plans. How do you determine a treatment plan? I mean, obviously it'll differ from patient to patient.
Yes. So a treatment plan is very individualized. And now it takes into account the type of cancer, the stage of the disease, the patient itself in terms of age, and pre-existing comorbid conditions. So there are certain types of treatment which we cannot use if, for example, if you've got kidney problems. Now, a lot of our drugs are excreted by the kidneys. So if you've got pre-existing kidney problems, then we have to tailor a treatment plan that will avoid certain agents. If you've got liver disease, then we have to tailor our plans that can avoid certain treatments that can be damaging to the liver. If you've got lung disease, then we have to tailor our plan, to avoid certain treatments that will damage your lung. So everything is based on what we see, obviously, on the biopsy, what we see on your imaging, and what we see physically in front of us in terms of the patient. Over and above that, we have a thing called performance status. Now, we score you based on your day-to-day activity and ability, or your functional ability. Now, if you're somebody who's fit and who can function normal day-to-day activities without any struggle, then yes, obviously we can troop on and give you stronger treatments. But if you're somebody who's bed-bound and need help for simple activities like even bathing and eating, then obviously we're not going to consider strong treatments for those type of patients.
Now, these conditions are more side effects of the treatment than of skin cancer itself.
Yes. So, and so a lot of the times, a lot of the times, like we said, the chemotherapy can cause damaging effects to the kidney. Now, if you've got kidney damage due to long-standing high blood pressure or diabetes, then we're not going to give you something that can potentially kill you. The chemotherapy can further damage your kidneys, which can potentially kill you.
Absolutely. We've got like a minute to round up. Do you have a message for our listeners?
So I think if there's any take-home messages from this talk is that every cancer needs to be investigated. Yes, skin cancer may not necessarily be as big as a problem as other cancers, but it certainly is a problem. If you are worried, no lesion is silly or small enough to get tested.
Just one question that comes to mind. I've got like about 30 seconds. If a member of your family suffered from any form of cancer, then what are the chances of other members suffering from a similar thing?
So it depends on the cancer type. So there are specific cancers that are linked to genetic mutations like breast, like colon, like prostate, like pancreas. Those type of cancers have a genetic link. So which means that if you've got a relative like a mum or a sister with breast cancer, then your chances of getting breast cancer are very high.
Okay.
Now when it comes to skin cancer, the only thing that has been identified is xeroderma pigmentosa, not necessarily your BRCA genes or your colorectal genes. So not as strongly genetically related as other type of cancers.
Dr. Presha Bipath, thank you very much for joining me in the program this evening. Unfortunately, that's all we have time for. And I'm really pleased that you did join us, and thank you for having shared the information with us.
Thank you so much for having me.
All the engineers of the various radio stations, thank you so much for having engineered. And I want to thank the listeners for having tuned in as well. I'll be back with you in 2 weeks' time on Medical Files. Till then, for myself, Fazial MJ Suleman, it's Assalamu alaikum wa rahmatullahi wa barakatuh.